Hi, good afternoon. My name is Mary Jean Pancho, and I'm submitting the PD catheter care plan video. So this video is to illuminate nursing role in the insertion of the PD catheter and provide exit site care teaching to patient, family, and caregivers. It is important for a nurse to encourage their patient to engage, learn, and ask questions, investigate, explore, and acquire deeper understanding of what they see and what they hear. In the existing literature, there is no consensus about the type of catheter that is to be preferred for successful peritoneal dialysis. However, it is generally accepted that PD catheter selections should be based on the individual patient's requirements as well as the local practice and experience. According to the Summary of Evidence by Mudge on the 2014, other guidelines also say that there are no recommendation of a particular catheter proven to be better than others. And that includes Kidney Disease Outcome Quality Initiative, UK Renal Association, Canadian Society of Nephrology, and European Renal Best Practice Guidelines. Because remember, the peritoneal dialysis utilization does not follow the same pace, attributable into the high technique failure rates, mainly due to peritoneal catheter dysfunction. When considering the relationship between PD catheter types and outcomes, we should keep in mind the different type of available PD catheters. Those that are commonly used in the clinical practice and those that are available for comparisons. The main difference in PD catheter includes the number of cuff, the shape of subcutaneous tract, and the shape of intraperitoneal tract. It is also very important to consider if the catheter should be used for long-term or short-term. Whatever availability there is of the best catheter design and materials, skillful management of PD access always have the greatest impact on the long-term patient outcome on PD. When considering for the catheter site selection, it depends upon the person's choices. So for example, when the person is wearing pants above the umbilicus, then the catheter should be better below the belt line. However, if the person is wearing the pants below the umbilicus, catheter is better above the waistline. And some people chose to put it on the upper abdominal, wherein there's less folds. And for the morbidly obese, they use pre-sternal. There are 7 types of PD catheter. The straight and coiled double cuff Tenkov catheter, straight and coiled swan neck catheter, Moyncreef-Popovich catheter, Toronto Western Hospital Type 2 catheter, Swan neck Misuari straight and coiled catheter, Cruise or pail handle catheter, and Swan neck pre-sternal PD catheter, which I chose. I chose pre-sternal swan neck catheter because it has a kink-resistant silicone material that provides comfort to the patient. Silicone is the most frequently used due to its biocompatibility, lack of trauma to surrounding tissue, and minimal leaching for plasticizers. This catheter is composed of abdominal and pre-sternal parts joined by the titanium connector here in the subcutaneous space of epigastrium and the exit site located on the chest wall. The main indication for this kind of catheter is for those who are morbidly obese, if they have ostomies, incontinent, they suffer from multiple exit site infection, and then they're avoiding trauma to the exit site. And also, for those who wants to continue their tub bath. It is usually good because it is there are less movement on the chest wall, and it facilitates the healing and decrease the trauma risk. But they should not be put on the sternum if in case the patient need an open heart surgery in the future. The rationale for me choosing this catheter is because it causes less abrasion to the exit site, and because it's made up of silicone, which reduces the danger of intestinal or organ harm during insertion and use. It's really biocompatible. Advantage of the Swan Neck pre-sternal catheter is that according to some studies, or a lot, it offers a better technique survival, it offers a better catheter survival, it reduces risk of exit site infection, and some who uses it says it offers them a better body image. A good choice for the obese patient with ostomies, incontinent, and have a problem at belt line. And it reduces the risk of preperitoneal calf infection. It also diminishes risk of tunnel infection because of decreased leakage and decreased calf extrusion. Disadvantages include implantation technique are challenging, and some of the patients also consider the worst body image with this catheter. It has a slower dialysate flow rate compared to abdominal catheter. Issues over disconnection on fast-growing children. And the higher risk of catheter colonization by bacteria during peritonitis with subsequent recurrent peritonitis. Pre-insertion care. It includes the pre-insertion assessment for hernia, for it to be repaired during and or before insertion of the catheter. You should also determine the PD exit site collaboratively with the patient in order for the patient to promote participation in care and self-management. Scar and abdominal fat folds should be avoided. Exit site should be in the position where the patient can see it and carry out care. And if the exit site is determined, a permanent marker is used to mark clearly on the skin. Before the operation, bowel prep needs to be done, and antibiotics should be given 1 hour prior. Monitoring laboratory values like CBC and INR, and holding blood thinners prior to procedure as per hospital guidelines. After the operation, exit site should remain undisturbed for 7 to 10 days, and exit site dressing needs to remain in place to minimize bacteria colonization and to promote healing. The catheter tubing should be immobilized to prevent trauma to the exit site and to prevent traction on the calf. Also, patient need to decrease intra-abdominal pressure to prevent leakage. PD catheter must be flushed with 500 to 1,500 ml of PD fluid to check for patency. And PD should not be started until healing at exit site and tissue ingrowth into the catheter. Dacron caps have taken place, usually after 10 days. If dialysis is required prior to the 2 weeks of healing, may do the APD with low volumes in supine to prevent leakage. Protocol for cleaning catheter exit site will depend on facility, whether that is soap and water or povidone iodine. Harsh solution should be avoided as they can cause skin damage, which can predispose to bacterial infection. May consider antiseptic solution if immunosuppressed patients due to infection risk for normal skin flora. Exit site should be covered and should be dried at all times to avoid maceration. Always secure the PD catheter to promote immobilization and to reduce risk and trauma and infection. Swimming and bathing can still be considered as long as waterproof or occlusive dressing is applied. Patients are discouraged to immerse exit site in water without the waterproof dressing. Hot tubs or activities such as diving, as it can cause tension to the catheter. So the nurse also need to assess, look, and palpate the site for to check for signs and symptoms of infection. Peritoneal dialysis is another form of dialysis used to remove waste products and excess water from body. It is a treatment that uses a lining of your abdomen called your peritoneum and a cleaning solution called dialysate to clean your blood. Dialysate is circulated through a tube, that's a catheter, inside the part of your abdominal cavity and absorbs waste products from blood vessels in your abdominal lining and then is drawn back out of your body and discarded. You can choose the type of peritoneal dialysis that best fits your life. It could be either do the continuous ambulatory dialysis that doesn't use a machine to do the exchanges, or you can use automated peritoneal dialysis or a cycler. Main difference are the schedule of changes and uses the machine or cycler, and other is done by hand or manually. You can do both in any clean, private place, including at home, at work, and or when traveling. Changes will happen on the patient's life that include but not limited to work schedule. Your schedule will change as you work your dialysis exchanges into your routine. Also, with your physical activity, you may need to limit some physical activity when your belly is full with dialysis solution. Also, there's some changes with what you eat and what you drink. The medication, the doctor may change it in order to manage your health. And in coping, adjusting to the effect of kidney failure and the time you spend on dialysis can be hard. So a counselor or social worker can answer your question and help you cope. Take care of your exit site, supplies, and catheter to prevent infection. So patients who agree and understand PD catheter therapy have a better quality of life compared to those who refuse any renal replacement therapy. Although patient could encounter catheter malfunction or infection, with the right intervention at the right time, patient will still experience the benefit of treatment and experience an improvement in their well-being. Thank you.